All right, IR Webiverse, are you out there? This is Ari Isaacson, and welcome to Balloon Occlusion Embolization Case Discussion. And myself and Dr. Rahul Patel are going to show you some cases in which we use a balloon occlusion microcatheter. We're going to show you some PAE, TACE, and radioembolization. And so the order of events is I'm going to go first and show a couple PAE cases, and then I'm going to turn it over to Rahul, and he is going to do the IO cases. So we'll have a opportunity in between to ask some questions, and then at the end we'll have another opportunity to ask some questions. With that, let's get started. All right, so balloon occlusion for PAE. I guess the question is why and how. What I'm going to talk about today is some of the challenges associated with PAE. I think anyone who has seen a PAE lecture or has tried a PAE knows it's a particularly challenging procedure. And I want to talk about how balloon occlusion microcatheters address those challenges. And then I'll show two cases in which a balloon occlusion microcatheter was used. So why is PAE challenging? Well, really it has to do with the anatomy. First of all, the anatomy is extremely variable. So identifying the origin of the prostatic artery is always difficult, and it's not necessarily symmetric from one side to the other. So that's the first challenge. And then the second challenge is once you've identified it, you need to be able to get a microcatheter into the artery. And a lot of times they're very tortuous, they're small, less than 2 millimeters, and they can arise at very difficult angles. And you can see from this image, which was done with a balloon occlusion microcatheter, that the catheter might have to traverse some very tortuous segments of prostatic artery. Also, what we try to avoid, obviously, when we're doing this, are complications from non-target embolization. Now, if you know about PAE, you know it's very safe. The chance of having a major complication from a PAE is less than 0.5%. But still, we want to try to eliminate as many of the minor complications as possible. And you can see here there was a non-target embolization to the inferior gluteal artery and resulted in this skin discoloration. Now, why does this happen? Well, it can either happen from reflux, from our particles refluxing proximal to where we're embolizing, or probably more commonly, it happens from pass-through of particles through anastomoses, arterial anastomoses that occur either within the prostate or right on the prostate capsule. And it can result in such complications as penile ulcer. And you know, like they say in any PAE talk, it's not a good PAE talk unless you have a penis pic by the 5th slide. And so there you go, we fulfilled that. All right, what about how can we prevent reflux of particles? Well, that's what balloon occlusion microcatheters were originally made for. This is an angiogram with a balloon occlusion microcatheter, but the balloon is not inflated. And you can see here that we have a nice angiogram of the left hemiprostate. But right here, there's a proximal branch that is supplying the bladder. This is the inferior vesical artery, and it's supplying the bladder there. When we inflate the balloon, and the balloon's inflated here, it's difficult to see because it's a DSA image, but now you no longer see that present because the contrast cannot go backward, and we still see maybe an even better picture of the left hemiprostate. All right, now this is the concept that I really want to stress today because I think this is the most important aspect of what balloon occlusion microcatheter contributes to PAE. It creates a protective pressure gradient. And so in this case, here is a balloon occlusion microcatheter, and we do an angiogram again of the left hemiprostate, and we see a nice left hemiprostate blush, but we also see this artery heading inferiorly toward either the penis or the rectum, probably the penis in this case. And so what happens when we inflate the balloon now, you can see the balloon outlined right here, is you no longer see that on the injection. And these are similar injections. They're not power injections, they're hand injections, and they're done not too vigorously. And what's happening is when you block flow around this catheter, you're creating a low pressure area in these vessels. And the low pressure area is going to draw blood upward. So right now, non-opacified blood is coming up from this anastomosis down at the bottom, and that's why we're not seeing it. It's no longer opacified with contrast. So here's a kind of a diagram from a paper that I did a few years ago. that shows that. And you can see here's the balloon occlusion microcatheter with the balloon down, deflated. And when you inject, you're injecting through into the prostate, but here's that arterial anastomosis that's going through the prostate down. This would be the internal pudendal artery down this way. When you put the balloon up, now you've blocked all flow around the catheter and you have a low pressure area here. That's going to create a pressure gradient that draws blood flow up through that anastomosis. So you're kind of reversing the flow in that anastomosis. And you can imagine how if you were embolizing, that would be a nice protective feature with flow coming up this way to keep particles from going through the prostate to other places. And I'm going to hope to demonstrate that in a case that I'll show you in a second. All right, so here is that case. So this is a 62-year-old male. He has a history of lower urinary tract symptoms. That's what LUTs are, lower urinary tract symptoms from BPH. And he's been taking BPH medications, but this is what we commonly hear. They no longer have the effect that they initially had. And so he doesn't want to risk a transurethral procedure like TARE because of the risks associated with it. So he's seeking a safer procedure, and that's how he came to PAE. So this is a clip of a cone beam CT, and a lot of times I'll do a cone beam CTA before the case to identify where the prostatic arteries arise from. And in this one, I want you to focus on the left side. Okay, we're over here. Here's the prostate here. Here's the bladder. And as you follow through, I'm scrolling through it right now. You can see there's a vessel. Oh, I think we jumped back. Let me go back to the previous one. There we go. You can see there's a vessel over. It's going to be over in this region here. Okay, go through again. Okay, so right here, there's this big vessel that's coming into the prostate, and when you have arteries that are that big coming into the prostate, they're clearly anastomoses because they shouldn't be that big at that stage of the prostate. There it is, right there, and you can see nicely it coming down. And this is the anterior portion. The penis is down here, so it's likely attaching to another artery here or anastomosing with another artery here, and getting flow that way. And so when we got down there with the catheter, this is what we saw. We saw the left hemiprostate and then this big vessel right here that's coming through. And we're not even seeing the continuation of it because there's flow coming upward. Now this is with the balloon down. And then the same image or the same angiogram with the balloon up looks like this. Now we're seeing even less of this because we've created this low pressure area here distal to the balloon, and now the flow coming upward is even more robust than it was before because of this low pressure area. And it's also interesting, you're seeing less blush in the prostate, and that's because all the branches supplying the prostate are kind of coming off of this vessel that's coming down this way, and because unopacified blood is coming upwards now, that's decreasing the blush within the prostate. So what did we do? We embolize, and people often ask me, well, how do you know what your endpoint is when you're embolizing with a balloon occlusion microcatheter? And the key is that it's not all that different than embolizing with an end hole, conventional end hole, because you still have flow. It's still free flow embolization, but the flow is coming from somewhere else. It's not coming from behind your catheter like it usually is. It's now coming from below. And so what you do is you inject a small aliquot and you watch. And if most of my fellows will tell you, I call it the yo-yo phenomenon, because when you inject forward and you push forward on the plunger of your syringe, you're going to see the embolic solution go forward. And when you release the plunger, the pressure driving from upwards is going to be greater and going to push it back. And so it kind of looks like a yo-yo. It looks like it's going up and down. And that's what we're going to see in this clip here. We're seeing kind of it go forward and back, and eventually it's embolizing the prostate, so the pressure here is increasing. And at some point, the pressure here is going to equalize the pressure coming up, and then we will reach a kind of a stasis. We'll reach stasis within this area. And it's important to watch carefully, obviously, because we don't want to keep pushing embolic downward, and we want to stop our embolization when we've reached stasis. And so that's the key, is to watch this yo-yo phenomenon until it's no longer yo-yoing up and down, and then you know you've reached your endpoint. All right, so that was case one. I'm going to move to case two now. This is just slightly different. So this is a similar history, a 63-year-old male, lower urinary tract symptoms. IPSS is what we use to grade the symptoms, and that's really bad, 28. He's got a large prostate, very large. Normal is 30, so this is more than twice normal. We did use a femoral access. Sometimes we do radial, but femoral because the patient was tall. And we embolized with 100 to 300 micron particles. Here's the initial angiogram, and you can see why prostatic artery embolization is difficult, because the angiograms can be really confusing. So there's prostate down here, but what's supplying it? Is it this vessel? Is it this vessel? It's hard to tell. We initially catheterized, this is going to be the lower one down here, so we catheterized that one, and we didn't see what looked like a prostatic blush. So we pulled back and did another run and tried to get into the right one. We got into another one, and this is clearly not prostate. This is pretty classic for what rectum looks like. So this is going to be the middle rectal artery. And so what I do sometimes is I'll do a contralateral oblique angiogram to try to differentiate the branches of the anterior division. And that's what we did here. And the artery that I wanted to get into was actually this one right here, and I wasn't getting into it until I got this view. And then we got there, and of course, then we see a nice left hemiprostate there. But what else do you see? You see this straight artery that's coming downward, that's going somewhere else, and we know it's not going to the prostate because A, it's straight, and there's no straight arteries in the prostate, and B, it's too large, it's too big of a caliber. And so we got down there, and it was going to the penis, so what we did was we put a coil here. So this, a lot of people don't know this is a 2.2 French Sniper microcatheter, and you can put an 018 coil through that, and it goes fine. And so that's what we did. We put an 018, this is a tornado coil. And so we coiled off this branch and then pulled back and redid our angiogram, and you can see now you have the left hemiprostate, and I blocked the outflow. Now you might say, well, why do you need a balloon occlusion microcatheter? I thought the whole point was to keep particles to change the pressure and keep particles going up. Well, this might be a different usage. And so what this is actually more of a high pressure embolization. So before we were counting on flow from below to come up and drive the particles into the prostate. Now we're just basically pushing particles in, but we can do it at a higher pressure because we've blocked the outflow. And so that's what we did. We embolized with the coil down here. And what did we see after a while? We started to see cross collaterals. And now you see what looks like the right prostatic artery. And so we finished embolizing and then went over to the right side. Well, sure enough, when we got into the right prostatic artery, this is what we saw. There's no prostatic blush there. And that's because we basically embolized the right side from the left because we were able to inject particles at such high pressure. And so after we were done, I got a cone beam CT. This is non-contrast, so all of the contrast within the prostate is retained from our embolization. And we saw that the full prostate had been embolized, both sides, so we didn't need to put any additional embolic on the right side. All right, so after 8 weeks of that procedure, his IPSS was excellent at that time, 4, that's really good. Went down from 20, I think it was 25 in the first slide. And then, and he didn't report any complications, which was really good. So I have a name for that type of embolization. I call it B-DOPE. It stands for balloon catheter distal occlusion, meaning distal coil occlusion, and then proximal embolization. I try to compete with Francisco Carnevale, but I really can't. But he's the master of acronyms. So this is the B-DOPE method. And so you coil embolize the extraprostatic anastomosis, and you use the balloon, which allows you to embolize at high pressure. In this particular case, particles went across the midline from the left and embolized the contralateral prostate. And this is a key lesson, I think, that coil embolization of anastomoses may improve the durability of PAE by preventing revascularization through those anastomoses. And the reason I say this is because we have a certain number of men who come back for repeat PAEs, and a lot of times what we see is that they've had revascularization through those anastomoses with the internal pudendal artery. So if you coil them off on your initial treatment, maybe you can make your PAE last longer. All right, so in summary, balloon occlusion, I think in the past we didn't have as agile balloon occlusion microcatheters, and so it was, the contemplating doing a procedure like this with one it wasn't possible. But now we do, and they have the benefits of preventing reflux, but also the benefit of allowing for or protecting from non-target embolization by creating a pressure gradient. And additionally, which I didn't put, which is the last point, we can also do high pressure embolization if we block the outflow with a coil. So with that, I'm going to, I think we have just a minute or two to take questions. Actually, it's 7:15. So if anyone has a question, feel free to type it in, and I'll give you a second. And if not, we'll move on to part 2 with Rahul. Okay, sounds good. One more, I'm going to plug my course real quick. This is the stream course. If anyone's interested in learning about PAE, this is a course that Sunny Bagla and I do twice a year, and it's coming up in September in DC. And if anyone's interested, they can go to streampae.com and sign up for that course. So now, with no further ado,
actually, Ari, we got a second here. I'm going to ask you a question.
You're going to ask me a question?
I'm going to ask you a question. I'm going to be that guy.
Okay, ask the question.
So, do you use?
By the way, this is Dr. Patel. Just so everyone knows. Okay.
So, do you use the balloon occlusion catheter on every one of your PAEs? And if not, how do you decide going in? Do you choose before going into the case, or as you're doing the case, you decide, to maybe use a balloon occlusion catheter?
That's a good question. So the way I do it is I usually do my internal iliac angiogram first, and there are some arteries that are really small and tortuous, and I want to get the most agile catheter that I can get. And in that case, I may not use a balloon occlusion. But if the artery is a normal to a large size, then I will go to a balloon occlusion microcatheter. And the other thing about it is that it gives you options. You don't necessarily have to use the balloon if it doesn't make sense. You can use it as a conventional end hole catheter, but it gives you the option to go either way. All right, any more questions? Okay, good. Well, without further ado, then I'm going to introduce Dr. Patel. Now, he said I should not introduce him, but I'm going to give him an introduction. I asked one of my colleagues here who used to be his fellow to describe him to me. My colleague described Rahul Patel as a master technician who can do the most difficult PAD case and then walk into the next room and then do the most difficult IO case. I thought that was quite a compliment.
All right.
So he's a associate professor of interventional radiology and surgery at the Mount Sinai Icahn School of Medicine. Ladies and gentlemen, Rahul Patel. All right, how about that for an introduction?
Yeah, that's a great introduction. Perfect. Okay, so I'm going to talk about a slightly different topic here. I'm going to talk about balloon occlusion catheters in TACE and TARE. So just a little bit of introduction. Balloon occlusion is based on a well-established physical property of fluid dynamics, whereby basically liquids, or even things that act like liquids, so small particles in a liquid, will flow from a high pressure to a low pressure environment. So the idea basically with this is, though, the balloon occlusion can potentially lead to either denser accumulation of lipidal emulsion in target lesions. So basically, this is the concept of high pressure delivery, or decreased non-target embolization, which in my mind I sort of wrap around low pressure delivery, and I'll sort of have some pictures and stuff to explain that. And just so you get a sense of how we do our chemoembolizations, this is sort of our recipe for TACE, for conventional TACE. It's usually 5 cc's of lipidol with 60 milligrams of adriamycin, which comes in 5 cc's of contrast. That's basically made with the emulsion, and then we give that, and then 40 micron particles usually behind to follow to reach near stasis. So low pressure delivery. So basically the placement of the balloon catheter is placed subselective or lobar, basically a couple of branches away from your target vessel, your target tumor. So think of it as a tumor maybe you couldn't get into. The balloon is inflated and the supply of the vessel is occluded, basically downstream, upstream. And so basically what that does is it creates an area where the tumor is low pressure. These arteries here, which would normally be flowing either away, basically flowing away to normal liver, now become reversed because the pressure in those areas becomes 60 millimeters, around 60 millimeters of mercury, as an example, and now everything's kind of flowing towards the tumor. And this is sort of on par with what Ari was showing when he was showing balloon occlusion and trying to reverse flow in some of those prostatic arteries that were going to the penis or to the rectum. So the same idea. And basically the embolic agent is injected slowly to maintain that low pressure system. So you don't obviously want to inject really hard because you'll just overcome that pressure gradient, and everything will kind of go back towards normal liver. And the embolization endpoint, so again, trying to figure out when to stop, is when you achieve stasis in the vessel that you want to target. So basically, once you start to reach stasis in this vessel is sort of when you're done. So here's a quick example of a patient for a TACE. There's a small little tumor. You're gonna have to take my take my word for it, in this little area right here. Here's the balloon up, and you can see basically once this balloon is up, this distal branch is actually starting to reverse. And the reason we couldn't get the catheter to go forward is actually this tortuosity was kept pushing us out a little bit. We couldn't get it to track really well. So we put the balloon up, and you can see reversal of flow. And I'm going to show you, this is the final TACE. So again, after we finished, we took the balloon down. You can see this distal vessel is still filling. And here on the spin, this is the pre with the balloon down cone beam CT. You can see the tumor and all the lateral segment filling. And then after with this is the final, so basically the catheter's still in, the balloon is down, but the embolization is completed. And you can see the sort of the good Lopidol staining in the little tumor here, a little bit of filling here, but the lateral segment is basically spared from the chemoembolization. So again, we really push our treatments. We'll treat patients who are really sick, child C, even child D patients, and we're able to do this sort of, again, we can be very selective or use the balloon occlusion to help and not have to be so subselective. So the idea of high pressure delivery, and again, this makes a ton of sense, is that you basically get the catheter into the area where the tumor is, so basically into the target vessel, you blow up the balloon, and you can basically slam in the chemo agent, right? So you're basically able to push a lot of the chemo in, no reflux, and you can sort of super saturate the area. So if you read some of the papers from Japan, they talk about this sort of chemo segmentectomy or chemical segmentectomy, and this is sort of the same way of performing this. You basically super saturate the area with the chemo agent. And again, the endpoint is basically when you get a dense stain of the tumor, or if you start to see contrast into the portal vein. And that's sort of the endpoint there. So here's a patient, again, this is the tumor right here. We're gonna blow up this balloon, but again, sort of child's PUC, sort of on the sicker side, and has this tumor here. And again, we're trying to get as durable a result as possible, so we put the balloon up, and here's the, again, we get a little bit further, here's the balloon going up. And here's the dense stain that you see afterwards with the chemo. And again, here's the spin done right after. And again, you see this very, very dense staining with the Lopidol and the chemo. And this is the 3-month MRI, or the 1-month MRI, sorry, showing basically complete necrosis of the tumor there. So again, a very good response with just a single session of chemoembolization. So here's another patient, again, just to show you again, we can do this for multiple tumors. And again, here, instead of trying to TACE the entire right and the entire left, we can basically sort of pick and choose these areas. So there's some areas in the segment 3. This is going to come back around one more time. You can see there's some tumors there. Oops, that kind of went best. So tumor there, and sort of all over. So again, we're going to try and pick off as much as we can and try to spare as much of the normal liver as possible, and go from there. So here's the cone beam CT from the main hepatic artery, and again, you can see multiple areas of enhancing tumor. He had a previous Y90, so that's what that cavity is. And again, you can see all these little tumor branches. And so what we decided to do was to basically say, okay, we have basically about 10 to 15 cc's of chemo agent that we can use. We're basically going to pick off the biggest tumors we can find and slowly do this one at a time. So again, here's I'm not going to show you every one, but here's the first one coming off sort of like segment 4-ish. Again, there's a tumor here. This is with the balloon down. This is with the balloon up. Again, you can see now this is actually getting a little bit denser here. We don't see as much of the normal liver enhancing, just more so the tumor. And this is one of the areas in the left lobe. And here's with the balloon up. You can see, again, more of the tumor here. And again, it's not as impressive on the angiogram, but when we did our spins and then when we actually ended up doing the chemoembolization, I'll show you the picture. So this is the balloon down, balloon up runs. And again, here you can see this is while we're injecting the chemo, you can see here these dense stains of the tumor from the segment 3. And here's a spin. This is the pre-angio, and then this is the post-TACE spin. So you can see these dense areas of chemo accumulation in these various tumor spots. And again, this guy's on nivolumab, but he's already had a TACE. He's okay. He's not sick. He doesn't have ascites, but we don't want to TACE the entirety of the liver. And again, he does very well ultimately. And I'll show you. I'll show you an MRI, post MRI here, and you can see these two areas of tumor are completely dead here and here. There's a couple tumors here that are still active, but they were stable. And given the way he was doing, and we were just continue to watch him. He was done actually about 2 months ago, so we're just going to watch him for now. So it's not a free cake. There are some pitfalls with this. One of the most common areas that we see problems with is actually in areas of in watershed areas, and this is a good example of what it is. And so basically, what you can have is a thick or a bigger area of intrahepatic communicating artery. And so when you have the balloon down, you can actually have sort of equal flow from this artery and from this main artery feeding the tumor. But with the balloon up, this bigger intrahepatic collateral is actually starting to take over and be the primary dominant supply of the tumor. And so it's actually filled by this. So you actually see less tumor stain with this. And so the way you can deal with this is a couple of ways. One is sort of a bad example, but usually what you can do is you can usually go just a little bit closer, and you can do this, or you can just end up TACing it with the balloon down. And this is, again, commonly seen in sort of these watershed areas in the liver. And I'm going to show you an example here of one we did for balloon using a balloon occlusion for radioembolization. This is sort of a different way of using a balloon occlusion catheter. So this is a guy who's B7, AFP is like 427 with an HCC here, sort of like in the middle of the right lobe. And these ones are tough because what ends up happening, especially when they're right there in the middle of the liver, they tend to be supplied by multiple branches, and maybe hard to isolate. So again, here is the tumor, and we did a spin, and what we found is that it's a little hard to tell because there's a lot of overlapping lines here, but there's basically some small arteries coming off of these two branches, and there's no real good way to give the radiation without sort of blasting the entirety of the right, about 2/3 of the right lobe of the liver is going to get Y90 here, and we don't really want to do that because we want to spare as much of the normal liver as possible. So you can see here in the diagram what we ultimately ended up doing was we actually made this really complicated, but basically put a balloon occlusion catheter here, a balloon occlusion catheter here, and then gave the Y90 from here, and I'll show you how that looks. So what we did is we came from the groin, which I know from Mount Sinai that's not normally what we do, but we did it from the groin anyway. We felt a little dirty. And I'm going to pause it right here. So go back a little bit so you can see the misregistration artifact. So we have basically two groin axes because we can put two balloon catheters. And we've done this before with just one, but basically a 6 French guide into the hepatic artery, or a proper hepatic artery, and then a sauce. And then through the guide, through the destination, we put two balloon occlusion catheters. You can see here, and then there's a microcatheter through the sauce into that feeding artery. So here's the run afterwards. And you can see we've spared all of this, and you can see the tumor now light up pretty brightly. And then we administered the radiation. Let's see. And so this is the 3-month MRI, which shows about basically 100% necrosis, and the AFP is down. And we were able to spare a lot of the liver doing this. So my final thoughts for this. So basically, balloon occlusion may be beneficial in C-TACE, conventional TACE. We've done it in DEB TACE as well, and it may be beneficial maybe in the bigger tumors, but in the smaller tumors, we don't do a lot of DEB TACE anymore. But basically, the question really is, can we increase the response rates and decrease the need for retreatments, and basically also decrease the non-target embolization, basically spare as much of the normal liver as possible. Again, keep in mind, it doesn't always work, but the answer is usually simple. Either go closer with the catheter or just do the TACE with the balloon down. Balloon occlusion may be beneficial for like distal protection in Y90. You can also use it for proximal protection as well, although we haven't really used it in that setting yet. And again, my shameless plug is for my meeting, which is the TREAT meeting, which we're doing in June, which is actually going to just be an online live webcast, which I think should be interesting. We're going to try to do 6 or 7 live cases and go from there. So I'm going to end there and see if anyone has any questions.
All right, there was a question for prostate back, so I'll address it real quick while we're waiting for other ones. It says, what are common origins of the prostatic artery? Okay, well, can basically arise from any branch of the internal iliac artery and occasionally from the external iliac artery. Most commonly, it arises from what's called a vesicoprostatic trunk, which is a trunk off the proximal anterior division of the internal iliac artery, or the internal pudendal. Those tend to be the most common, but the obturator is another pretty common one, and then there's some weird ones that can come off other places as well. What else? Let's see. Yep, there you go. You want to take that one?
Yeah. So do you see forward flow distal to the occluded vessel? I'm not sure what they're asking, but I think what they're trying to say is, do you see flow maybe retrograde through collaterals through the vessel?
Yeah,
so
I think that's the question. Yeah.
Yeah, so typically no, because we're trying to get, even with the balloon catheter, we're trying to get as close as possible. So we're basically taking down the target segmental or subsegmental artery. So we typically don't see occluded vessels. But in the one example I did show, we ended up TACing, proximal, and then that distal vessel still remains patent because it was sort of retrograde filled while we were embolizing it. But yeah.
Yeah, so in low pressure embolization, if you're doing low pressure, you're probably going to see some forward flow, because you're going to have those collaterals that will reverse and allow forward flow. When you do high pressure and you really get it up close to the tumor, then you're just completely shoving stuff in there at high pressure.
Yeah. Exactly.
So I presented on this I think it was a couple years ago now at Guest, and all of the literature on balloon occlusion until recently came from Japan. And there is a kind of a small cohort of Japanese IRs that really believe in it, and then there's a much larger cohort that think they're crazy. And they came up to me afterwards to make sure they told me they thought that they were crazy. But it's interesting why it doesn't. There is some pretty good data out there. Now, there hasn't been a randomized controlled trial, but there's been a lot of comparison to historic cohorts that show they get better results when they're doing balloon occlusion conventional TACE. Rahul, do you have any idea, why do you think it's not getting accepted as rapidly as one might expect?
Well, so first of all, in the U.S., it's just we haven't really had a good option up until relatively recently. So that's the U.S. In Japan, they've actually had a catheter for a very long time, for many years now, which is actually quite good. But there are people who they have different ways of doing their TACEs, and it's a little bit strange, but they actually have a microcatheter that goes through their microcatheter. So some of them won't do the balloon, but what they'll do is they'll actually use this like secondary microcatheter to go out super far into the liver. And so that camp believes that they don't really need the balloon because they're going to go out super selective like that, and sort of really just jam in the chemo as much as they can. Yeah, they've definitely gone into two camps there.
Now, you spoke about conventional TACE, but if I'm not mistaken, you guys recently put out a paper about DEB TACE with balloon occlusion. Is that right?
Yeah. So Aaron Fishman, one of my partners, does actually, I think he's the only one left that does a lot of like DEB TACE. So he's done it, and it works. I just like the conventional TACE better because I feel like I can get. I'm really trying to like really super saturate these tumors because we're getting really close. So I feel like I can get a more consistent result with the conventional TACE, a more predictable result with the conventional TACE. With DEB TACE, it's always somewhat unpredictable how much of the chemo I'm actually getting in if I'm just torturing the vessel. Yeah,
that's true. And so until not so long ago, we didn't have an option for radial.
Right. That was the other thing. So now we have a 150 balloon occlusion catheter, which is So that's also very helpful.
Very helpful.
Even for your prostate as well. So.
Yeah, very much so. Very much so. All right. What else? Any other questions out there? All right. I guess one last chance for any comments or questions before we sign off. All right. Well, I think that was pretty good. So, final thoughts, Rahul?
Not really. I think I kind of went over all that stuff, so I'm good. So
you're done? All right, fair enough. All right. Well, thank you for spending some time with us, and I hope you enjoyed the cases. And you could probably figure out how to reach either Rahul or myself if you have a question to ask that you didn't get to ask here. So with that, I will we'll say goodbye.
All right. Bye, everybody.